Hi, Adult Health 1. So this is Module 8B. This is intestinal disorders, hepatic disorders, and biliary pancreatic disorders, Chapter 58, 59, and 60. Here are our objectives. So we're going to start with Chapter 58, intestinal disorders. So the intestinal system is composed of the small and large intestines, right? Main function is to digest, absorb, and eliminate waste products. So our main concern with this, though, is obstruction. So when the normal flow of contents through the GI system becomes blocked, and this can occur in the small or large intestine, we are worried because obviously the bowel can explode, people can go septic, stuff can leak, all of that stuff. So normally small bowel obstructions often occur as a complication of surgery. So any of those GI surgeries that we talked about, afterwards, or really anything, because I mean, afterwards, people are on opioids, and a common side effect of opioids is reduction in bowel motility, right? Because the opioid slows everything down. So if people are really not paying attention to or haven't been educated to make sure that they need to still be pooping somehow, whether that's an enema or suppositories or, whatever it may take, they can get to the point where they end up with an obstruction. Large bowel obstructions do occur, but they are only about 25% of intestinal obstructions that we see. Those can be related to like malignancy, like tumors, hernias. Intestinal hernias are where part of the intestines becomes like trapped in either the stomach muscle or just some other area, and it gets obstructed and a bowel blockage happens. You can also have adhesions, which are scarring from previous surgeries, strictures, which are like little, where inflammation has inflamed the bowel to the point that it's super skinny. You go from a boba straw to a little swizzle straw trying to get through. You can see it with diverticulitis, polyps, stuff like that. Large bowel obstructions usually require a surgical intervention. Okay. Small intestine obstructions are signs and symptoms. We're going to see abdominal distension proximal to the obstruction, right? So below the obstruction. This is because of the accumulation, sorry, not below, above, due to the accumulation of chyme and intestinal gases. Patient's going to have pain, cramping, maybe even intermittent. If the pain is continuous and severe, we worry about strangulation of the intestine, and this requires like immediate emergency surgery because we are worried about necrosis or ischemia. Patients can have nausea, vomiting. Keep in mind, of course, this could lead to electrolyte imbalances. You can have complete obstructions or incomplete obstructions. So a complete obstruction, we would expect that bowel sounds to be absent, that the person has not had a bowel movement, or gas, right? But with incomplete can be tricky because the person may still have bowel sounds, may have had a bowel movement. One of the things we talk about related to small bowel incomplete obstructions is you can get like thin ribbon like poop because the intestines is blocked, but that there's a little opening still, so the poop is still able to move through. Diagnostics, they use imaging. Treatment, we may put our person NPO, NG tube suctioning for to help with that accumulation of fluid and gas. Possibly IV therapy if our person is NPO, and especially if they're on suctioning, right? We may have to do electrolyte treatment, steroids sometimes for inflammation. And then, of course, surgical, right? If there's a complete obstruction, they may have to go in. If it's related to adhesions, they're going to remove the adhesions. Usually a lap technique is used, so it's not like they have to cut you open anymore. So it's still not a great surgery, especially if they have to remove intestine, because you always have the threat of coming out of that surgery needing an ostomy, at least for a little while. So complications, perforation, right? Bacteremia, sepsis, intraabdominal abscess, all of that stuff. We always worry about a patient going septic related to a bowel obstruction, because all of those toxins and stuff that are in the bowels do not belong flooding the body. So if we end up with a perforation of some sort, or the bowel burst, it's a very bad situation. So RN considerations related to intestinal block, our priority problems are going to be acute pain, fluid volume deficit. We're always going to worry about hypokalemia if we have vomiting or nasogastric suctioning. Obviously following vitals, looking at temp because of option or threat, I should say, of sepsis, right? We're going to look at I's and O's, see what's moving. Bowel sounds, of course. Always the electrolytes and WBCs. And then pain. If they've gone in for some sort of bowel surgery, they're going to be in pain afterwards. And then, of course, if we use opioids, we have to be considerate of the fact that we're back into possibly causing peristalsis, right? Where there's no movement in portions of the bowel. So actions, we want to keep our patient NPO until the physician says it's okay. Make sure they're on some sort of IV fluid, antiemetics, NG tube. Don't forget about oral care. When people are dry, you can get a lot of cracking, and that can lead to sores, which is just uncomfortable. If your person's vomiting, you want your head of the bed up so that we don't risk aspiration pneumonia, or just aspirating, period, right? Then we're going to have pre and post-op teaching. Post-op teaching could include ostomy care, right? If they come out of a bowel surgery with an ostomy, we're also going to want to really focus on the importance of ambulation. Get up, walk around, do some things, because that helps the bowel keep moving, and it keeps everything else healthy. All right. Slide 6 is about hernias. Hernias are when there's a protrusion of abdominal contents through an area of weakened muscle in the abdominal cavity. One of the oldest recorded afflictions of mankind. There you go, fun fact. Hernia can be congenital, so born with it, or acquired. Typically occurs because of weakened abdominal muscles accompanied by increased abdominal pressure. So like if you're doing heavy lifting of some sort, straining, anything like that, you can actually cause a hernia where part of the abdominal contents will push through the muscle and protrude. The biggest thing we worry about is strangulation, and that basically means that those that portion of the abdominal content actually gets completely closed off by the muscle that it has protruded to, right? So then we worry about ischemia, necrosis, that whole thing. And you get back into the whole sepsis, all of that. A lot of times hernias will require surgical intervention. They go in, they may cover the area where the muscle has been broken through with a mesh, right? So they'll put a mesh in there so that the bowel cannot push through anymore. If it's a smaller hernia, they may actually use like a really tight binder, which kind of holds the muscle in place and doesn't allow anything to push through again. Diagnosis, typically based on physical exam. They can use X-ray, ultrasound, CT, MRI, any of that to confirm diagnosis. But a lot of times you can feel a hernia, you can see it, and then just by the description, you're able to identify it. So non-surgical treatment, like we talked about, probably a binder. But surgical is most common, honestly. They go in and repair that. They do that mesh. Um, and this too is usually done as a lap surgery, laparoscopic. So it's not like they have to totally open you up. There's just afterwards, there's precautions related to, lifting and all of that sort of stuff. Slide 7 is a picture of different types of hernias, like where your hernias can commonly be located. We have inguinal, femoral, umbilical, just typical areas where those abdominal contents like to push through, right? Slide 8 has some safety alerts on it. The first one is the patient with a strangulated hernia may present with clinical manifestations of an intestinal obstruction. So it's going to look similar. This is an emergency and the patient must be prepared for immediate surgery to prevent gangrene from developing. Strangulation signs and symptoms include abdominal distension, nausea, vomiting, pain, fever, and tachycardia. So we need to keep both of them in mind when somebody presents with those symptoms, right? The second safety alert says that although post-op patients should be encouraged to turn, cough, and deep breathe, the patient who has undergone abdominal hernia repair should not be encouraged to cough. This would place pressure on the surgical site and increase the incidence of reoccurrence. If the patient needs to cough, encourage splinting with a pillow to prevent injuring the surgical site. So that just means splinting with a pillow. If somebody has to cough, sneeze, something like that, they hold a pillow to the site, kind of like what the binder would do, right? Where we give it just a little bit extra cushion so that we don't go and blow through that abdominal wall again. With cardiac patients, anytime they have surgeries, they'll give them a heart pillow at any of the cardiac places. And that also is to like hold in place if you have to cough, sneeze, anything like that. So it just helps maintain the integrity of the surgical site. RN considerations related to hernias. Just keep in mind clinical manifestations of hernias are closely related to the location and type of hernia. So clinical presentation could include bulging or swelling at the side of the hernia. They can be achy, that kind of radiates, feelings of fullness or pressure. They could have nausea, vomiting, abdominal distension, depending upon what's going on. Our priority problems are going to be acute pain and then risk for infection if they go in for surgery, which is likely. And then, of course, we worry about knowledge deficit after surgery. So assessments of course vitals, of course pain, I's and O's, surgical site, actions, deep breathing and early ambulation, pain meds as needed. We want to make sure that they go home with pain meds. And then, of course, if they go home with opioids, we want to talk to them about bowel care and all of that. If they have an inguinal hernia, this can affect the scrotum because I don't know if you've ever seen a swollen scrotum, but it is crazy how much fluid the scrotum can take on whenever there is swelling in that area, whether it's GI or bowel or whatever. So you can apply an ice pack to a scrotum, also elevate. You can elevate the scrotum. In the hospital, we always use a pillowcase and you make a little sling and you sling the little guy up and basically you're letting gravity be your friend. Because that can be alarming both for us as nurses and for the patient. So the diet for the patient is going to begin with clear liquids and go from there. Don't forget that nausea and vomiting are common after anesthesia, so we want to be careful related to aspiration. Teaching, coughing is discouraged. You can't lift anything heavy for a few weeks. Your prescriber is going to go ahead and give you whatever their strict instructions are. You know, maybe it's 2 weeks, maybe it's 3 weeks, maybe it's no more than 25 pounds, whatever. They'll give you specific instructions. We're also going to want to talk about monitoring incision sites, looking for signs of infection, and if there are signs of infections, to notify the healthcare provider. So moving on to hemorrhoids, these are swollen or dilated veins in the anorectal area. Basically, they are varicose veins of the rectum. They can be caused or precipitated by straining during defecation, prolonged constipation because you have everything pushing, heavy lifting, prolonged standing or sitting, portal hypertension, so like related to cirrhosis, increased abdominal pressure, pregnancy, obesity, heart failure. 40% of hemorrhoids are asymptomatic. There can be bleeding. The bleeding is usually painless, and usually seen like during a bowel movement, right? It's also usually associated with internal hemorrhoids. External hemorrhoids, they can be itching, they can get irritated because they're hanging out of the rectum, right? So, you know, there can be basically rubbing and stuff that causes irritation. So they can be painful and annoying. Clinical manifestations, that pain, pruritus is the itching, the bleeding. Some hemorrhoids may prolapse during defecation and spontaneously return after defecation, meaning they kind of go away or go back inside and then come back out. And pain can range from mild to severe based on the size and number of hemorrhoids. Okay, so diagnosis, external hemorrhoids, that's just going to be visual inspection. Internal can be a digital rectal exam. They can also use an endoscopy basically to go on up in and take a look around. Treatments is conservative, so they try to do the least thing first, right? So this may be cold packs, sitz baths. Sitz baths, a lot of times you'll see this used for ladies after they've had a baby. It's basically warm water, and you can use something like Epsom salts or something like that, and that just helps reduce the swelling. There's also tons of over-the-counter products. You know, there's wipes, there's little tuck wipes that are made with, they have witch hazel. Witch hazel is supposed to help reduce hemorrhoids. There's stuff that you can use to help with the itching and the burning and all of that. So after about 3 to 5 days, if like conservative therapy has not helped the situation, then you go back to your primary care. There are surgical interventions that may be recommended. Don't forget, part of conservative care is making sure that you're drinking enough fluid, fiber, all of the stuff to keep constipation and hard stools from happening. So you could use stool softeners, anything like that. Let's see. So surgical intervention, usually done on an outpatient basis, you know, kind of the last resort. So RN considerations related to hemorrhoids, priority problems, obviously pain, and then risk for altered bowel elimination. So this person has had hemorrhoids removed or whatever, but we still have to make sure that they are able to poop and pass out that waste material. We're going to want to watch vitals related to infection, visual inspection of the rectal area, make sure that everything is looking appropriate. You're going to want to track your bowel movements just to make sure that you're pooping enough and not getting constipated. Actions, pain meds as needed, local like topical anesthetics, astringents, which actually promote skin dryness and relieve itching. That's like the witch hazel. They may use steroids or topical steroids, cold packs and sitz baths, laxatives. Teaching is going to be care of a surgical site if that is what had to happen. And then, of course, prevention of constipation. Also avoid straining, because straining you can end up with hemorrhoids if you're straining a lot. Then all of our over-the-counter options, and then also contact the healthcare provider if you're unable to urinate. Urinary retention can occur because of rectal spasms and pain, and also if you're constipated, you can have so much fecal matter in there that it's pressing down on the urethra and you're unable to urinate. So that would be a big problem. All right, we are moving on to irritable bowel syndrome. Slide 12. Exact cause of irritable bowel syndrome is unknown. The mucosal lining of the bowel remains essentially unchanged with symptoms. Other names that may be used for IBS include spastic colon, nervous digestion, spastic colitis. It's characterized by areas of bowel spasm and dilation. It is associated with conditions like fibromyalgia, chronic fatigue syndrome, GERD, functional dyspepsia, non-cardiac chest pain, depression, anxiety. There's no known cure. Okay, it does occur twice as often in female patients as male, and often clinical manifestations will worsen with the menstrual cycle. So because of this, they kind of think there's a hormone component to it. So there's 4 subtypes of IBS. You can have IBS that is primarily constipation. You can have IBS where you primarily have diarrhea. You can have IBS where you kind of alternate between diarrhea to constipation, and then IBS unclassified, which just means IBS diagnostic criteria met, but it just cannot be accurately categorized. So clinical presentation, you can have diarrhea, you can have constipation, you can have gas, abdominal pain. A lot of times patients will report left lower quadrant pain and abdominal distension. Alternating bouts of diarrhea and constipation, not uncommon. A lot of times the pain increases after eating, but is then relieved when the person has a bowel movement. And the pain has been known to increase with emotional stress. Treatment for IBS, totally symptom-based. Because there's so many variations for each patient, it's going to be on an individual patient basis, right? So there's no diagnostic tests that show definitive diagnosis. However, they will do other tests just to rule out other causes. A diet high in fiber may help control symptoms, just because it helps make bulkier stools, and bulkier stools reduce tension on the sigmoid colon, so that can help with pain and stuff. There's also a lot of herbs that people will use related to relief of IBS. Peppermint, herbal teas such as chamomile, and then ginger is supposed to help with nausea and expel gas. So it might not be uncommon to see what kind of stuff, like alternative stuff, people are using. That would definitely be a question we would have for a patient. This is a safety alert, slide 13. There is a reported increase in the use of herbal remedies in recent years. Medicinal herbs are classified as dietary supplements and are not regulated as medications in the U.S. When patients choose to self-administer herbal remedies, teaching must be provided to make them aware that many herbal remedies can interfere with medications they are taking, and the healthcare provider should be consulted. Patients are taught to obtain information related to the herbal medication of their choice from reputable sources, and then online sources include the following. This is kind of a nice slide because it does offer some resources for people who are taking supplements. To find out about recommendations and interactions and that sort of thing. So our priority problems related to IBS, pain, right? And then, of course, there's going to be psychosocial effects. Maybe this person's afraid to leave the house because they don't know if they're going to have a bout of diarrhea, right? So it can be hard to live with for people. We're going to look at vital signs because we're worried about the risk of dehydration if they are having diarrhea. We're going to worry about electrolytes. Uh, we want them to track their bowel pattern, right? If you eat this, then what happens? You know, when do you have constipation? When do you have diarrhea? What's going on? Are you stressed out? Like, what's happening? We would want people to track their weight as well. And then we do want to take into account that psychosocial aspect. So our actions, you know, this is not a fun topic to talk about. So if you can build a trusting relationship with your patient, it might just be easier for them to really talk about these things. Also, we want to do teaching about foods that exacerbate clinical manifestations of IBS. So caffeine, alcohol, you know, those increase GI motility and can irritate GI mucosa. So those would not be good. Avoid those if possible. And then anything that kind of like produces gas or discomfort, you know, milk, beans, stuff like that. So just avoiding foods that don't sit well. And believe it or not, this is one of the times when we kind of recommend complementary and alternative medicines because they have been shown to be helpful. But again, you know, we want to look at what other medications they're on, you know, give them those websites to research, or we can research with them, whatever. And then also, because of the psychosocial aspects, we may want to recommend support groups. And that's pretty true for like all of these GI things because they can be difficult and embarrassing to live with. So then teaching is avoiding trigger foods, keeping a diary, consuming regular meals and drinking 8 to 10 cups of liquid per day. Anything that has to do with bowel movements, we always worry about having enough fluid, right? We also want to encourage exercise and 7 to 8 hours of sleep each night. Stop smoking. You know, smoking doesn't ever help anything. And the way that it causes vascular constriction, it just usually ends up exacerbating problems. All right, inflammatory bowel disease. So this is IBD. So this is an umbrella term for two very similar chronic diseases. So it's for Crohn's and ulcerative colitis, all right? So IBD refers to both Crohn's and UC. Diagnosis can occur at any age, but is more likely to occur between the ages of 15 and 30. And then there's like a second peak between 50 and 80, right? Exact cause is unknown. It's linked to genetic predisposition though, and then environmental condition, defects in immune regulation. So not that they're calling it autoimmune, but that certainly sounds autoimmune-ish, right? Let's see. Exacerbations are often precipitated by physical or emotional stress. Although there are similarities, there are also many differences between Crohn's and UC. Similarities include persistent diarrhea, abdominal pain or cramps, potentially fever, weight loss, fluid and electrolyte imbalances, malnutrition, because if you're having constant diarrhea, nothing is being absorbed appropriately through the small intestine, right? It's just going in and passing through. So you end up with malnutrition. You can get anemia, bleeding. Believe it or not, you can get joint, skin, or eye irritations, and then delayed growth. And delayed growth, again, would be related to the fact that nothing is being adequately absorbed, all right? There's no medical cure for either disease. They can do a colectomy, which is removal of the large intestine. That cures ulcerative colitis in the GI tract. However, having a colectomy does not cure the extraintestinal manifestations associated with UC. So there's still other signs and symptoms that go on, unfortunately. So treatment, primary goal of treatment, rest the bowel, right? Control that inflammation. You want to combat infection, correct malnutrition. You want to alleviate stress because this is really a stress-related thing. And then, of course, we want to do whatever we can to provide symptomatic relief and improve quality of life. So this may be meds, it may be surgery, psychosocial needs, whatever needs to be done, right? They diagnose this using a colonoscopy. Maybe they do a sigmoidoscopy, barium enema. Um, those are used for Crohn's and UC. Meds, patient with IBD is taught the importance of adhering to prescribed medication management. So the thing is though, these meds that are used can often have unpleasant side effects as well. So this is table 58.4. Just look at some of this because we do want our patient to let us know if they're having any signs and symptoms related to these meds. And then, of course, we want to do education related to the foods to avoid. So that's milk, gluten, caffeine, chocolate, cocoa because of the caffeine, citrus juices, very acidy, cold or carbonated drinks, nuts, seeds, popcorn, and alcohol. All of that can be irritating. So this is Crohn's versus UC, all right? So Crohn's is not uniform in appearance. It has like skipped areas in the bowel. It gives it this like cobblestone appearance. On our slides for class, there's a really good picture of what the cobblestone appearance can look like. It's crazy. So, but the thing is, all these lesions that occur, they're ulcerations. So you get ulcerations between the inflamed tissues. So think about how just painful that must be, right? Crohn's can also occur anywhere in the GI tract. So mouth to anus, you can end up with these ulcerations. The diarrhea tends to be less severe with UC. But you still have like the nutritional deficits, abdominal pain, large intestine, UC affects the large intestine, but only the mucosa and submucosa, all right? So, and the thing with UC is it starts at the rectum and spreads up. All right. With Crohn's, there is no pattern whatsoever. UC starts in the rectum, spreads up. All right. Diarrhea, very common. They actually can lose like several liters of fluid per day because they can have up to 20 stools per day, 20 loose stools. Like, how are you supposed to have a life, right? I mean, this could be very debilitating. You can have blood, mucus, and pus with ulcerative colitis, abdominal pain. The tenderness from UC is going to be in the left lower quadrant. We always worry about fluid and electrolytes, right? So we encourage this patient to rest and we want them to decrease bowel motility. Anything that we can do to help slow down that inflammation and that whole process. So this is table 58.3. This is slide 17. This directly compares Crohn's to UC. Sorry, I'm coughing. My nose is running. My allergies are driving me nuts. So table 58.3 compares Crohn's to UC. So this is a nice little table in the book, or just use this slide. So RN considerations related to inflammatory bowel disease, definitely deficient fluid volume because of the diarrhea, right? We'd also worry about electrolytes, nutrition, ineffective coping, right? Because of the psychosocial aspects. Vitals we're going to worry about because of hypovolemia. We're going to want to know the frequency and characteristics of the stools. If there is any blood present, like it could just be related to irritation, but we also worry about other things too, right? Including cancer. So you're going to want to know if that's happening. We want to make sure they're taking in enough fluids. We're going to worry about daily weights. We're going to encourage small, frequent meals because it's easier for the body to digest. And then, of course, all those foods that we want them to avoid. And then we're going to make appropriate referrals to interprofessional teams to help with this. This could be support groups, dietitian, anything like that. We may have to think about pain management. Because this person is potentially having up to 20 loose stools a day, you really need to think about skincare, right? Because think about how you could have just skin breakdown in that area, and then we're worried about infection. So the teaching is dietary, also keeping a diary, what helps, what doesn't help, and then of course the importance of all of their follow-up appointments. Celiac disease, moving on, slide 19. This is a genetic autoimmune disorder that damages the small intestine. It's related to eating foods that contain gluten found in wheat, barley, and rye. Gluten is not only found in foods such as bread and pasta though, but it is in like hair and skin products. It's in all sorts of crazy things. So people really have to be aware of where to look for gluten. This can be a very serious disease process for people. It can cause long-lasting problems, particularly with malabsorption, because the gluten actually destroys the little cilia that help with absorption. And so a lot of times people will have malnutrition. A lot of times this is diagnosed in childhood because the kid is going to go out, have spaghetti and just feel sick, or eat a sandwich on bread and just feel nauseous and sick, and they're eating but not gaining weight. So you'll see this a lot in kids. And then for celiacs, the thing that you have to do is adhere to a gluten-free diet for the rest of your life. And actually, if you can do that, that is really good. That's good management. You'll be fine. All your problems will be solved. So we want these people to consult a dietitian. We want them to understand the importance of the fact that it is lifelong. Signs and symptoms when they do eat gluten, they can get diarrhea, flatulence, bloating, all of that. They will have steatorrhea as well. We talked about steatorrhea with our cystic fibrosis patients because that's that greasy, fatty stool because the body is not absorbing things correctly. So same deal with celiacs. The body's not able to absorb things correctly related to the gluten intolerance. So they end up with steatorrhea. Our RN considerations, we really worry about dehydration and malnutrition, right? Electrolytes, I's and O's. We want to know what their stool characteristics are, again, because of that steatorrhea. They can actually use a DEXA scan to diagnose if somebody has either osteopenia, brittle bone disease, or osteoporosis, weak bones, related to the malabsorption problems, because the body's not absorbing the calcium, and so a lot of times people end up with bone diseases related to this. You want to talk about the fact that gluten is not just in the foods that you think it's in, that you really have to check all the labels for all the things. There are support groups out there that would be helpful. And then you're going to want to talk about what to do when dining out, right? What are the options? What can patients ask for? So talking about reading food labels, there are gluten-free resources out there. Lots of information on the internet, obviously, right? So the nice thing about celiacs is there's lots of help out there. All right, now we are talking about diverticulitis. So slide 21. Diverticulum are small pouch-like protrusions or herniations, most often occurring in the GI tract, particularly the colon. Diverticulitis occurs when this protrusion or herniation becomes inflamed or infected, most frequently in the left colon. And it's thought to be related to a lack of fiber in the diet, obesity, and lack of physical activity. So risk factors for diverticulosis include increasing age, obesity, smoking, low fiber diet, hereditary, and some meds like NSAIDs, acetaminophen, steroids, and opiates. There's also been an association between eating red meat and high fat diets with the risk of diverticular complications. So your signs and symptoms are going to be abdominal pain over the area that is involved. This is usually the sigmoid colon. They may have a fever, leukocytosis. You may even be able to feel like a mass over the area involved. The person may have bloating, distension, diarrhea, constipation. You can have mucus and bleeding in your stools. We're going to diagnose this related to, first we're going to do an x-ray and then potentially confirm with a CT. So uncomplicated diverticulitis can be treated on an outpatient basis. They may use broad spectrum antibiotics, 7 to 10 days, reassess in 2 to 3 days, see what's going on. We advise a clear liquid diet until symptoms subside. So, not very fun, broth, jello, that sort of thing. And then you advance the diet as tolerated. If the patient ends up in the hospital, we're going to go NPO, we're going to use IV fluids. They're probably going to have a nasogastric tube for bowel decompression. They actually want you to avoid laxatives and enemas because they increase intestinal motility. And we are trying to give the bowel a break, right? So we actually don't want to use those. You may end up with pain meds. When clinical signs and symptoms completely resolve, they may go back and do a colonoscopy just to see the extent of the diverticulitis. If there is a perforation, obstruction, abscess, something like that, then they may do surgery, okay? Priority problems related to diverticulitis, pain, absolutely, pain, and then hypokalemia, and that's related to using the nasogastric tube suctioning. Vitals, we're worried about fever, signs and symptoms of infection like tachycardia. We are always worried about that potassium level, I's and O's. Older adults, this is another one where we have to take into consideration our older adults and the fact that they don't always show signs of like classic infection, right? So our first sign or symptom may be mental status changed. So altered level of consciousness, right? Maybe early in the morning your lady's A&O by ×4, and then you go to leave and she's, telling you that it's 1954, whatever, something like that. So our actions are going to be related to giving the fluids, whatever fluids are ordered, antibiotics, monitoring that NG tube, monitoring the potassium, teaching afterwards, dietary, fluids, all of that. Avoid straining, bending, and lifting. Just because these can increase intra-abdominal pressure, which can lead to further outpouching of the diverticula, okay? And then if weight reduction is called for, definitely weight reduction. If your person's on antibiotics, we want to make sure that they take all those antibiotics. All right, appendicitis. Acute inflammation of the appendix. This does affect males more often than females, and is commonly seen between the 10 to 19-year-old age group. So appendicitis may be a result of a fecalith or other foreign body blocking the opening, leading to inflammation and subsequent infection. Other less common causes may include tumors, twisting and kinking of the appendix, edema of the bowel wall, adhesions, or other infections. When the opening to the appendix becomes blocked, the mucosa begins to secrete fluid, leading to venous engorgement that increases intraluminal pressure and restricts blood flow. Subsequently, bacterial invasion occurs, and an abscess may develop if this process occurs slowly. Gangrene can occur in as little as 24 to 36 hours. Isn't that crazy? And this is definitely life-threatening. Perforation can happen after 24 hours, but then of course that risk increases after 48 hours. This too, life-threatening, because again, we are flooding the system now with toxins that shouldn't normally be there, right? So people can go septic and it gets bad pretty quick. Signs and symptoms. So patients will present with periumbilical abdominal pain. Maybe they don't feel like eating, they're nauseous, maybe some vomiting. The pain is going to be in the right lower quadrant, okay? It's going to be severe and steady. We call this area McBurney's point, all right? It's in 58.6. So right lower quadrant, McBurney's point, severe and steady pain. Now the thing is, if this pain suddenly goes away, we're worried because that means the appendix has burst, and that is a problem. So if your patient comes in and they are doubled over and we're thinking appendicitis, and suddenly they're actually like, Ashley, I think I'm great, be worried, okay? Diagnosis related to clinical presentation, physical assessment findings, they can do an ultrasound or they may do a CT. Treatment, traditionally no medical management was warranted for acute appendicitis. However, some patients with uncomplicated appendicitis have been treated with a 7 to 10 day course of antibiotics. Let's see. 30 to 40% of uncomplicated patients will go on to get an appendectomy. So if surgery is appropriate, you know, surgical consult, you know, kind of an emergent situation. Do not use laxatives or enemas because they can increase that intra-abdominal pressure. And then we worry about the perforation, right? That's always a problem. They may do a laparoscopy just to take a look around. They can do an appendectomy just with a lap. So again, you're not talking about being cut open and incisions being crazy. Now, if the appendix ruptures, that obviously is a much bigger problem and going to be a much bigger surgery. Here is McBurney's point for you. This is slide 24. So our priority problems, obviously pain, right? Pain is a big thing. We are going to worry about fever, vomiting, electrolyte imbalance, and dehydration. We're going to worry about risk for infection related to perforation. So we're going to watch the vitals, I's and O's, possibly WBCs with a differential because we want to know what's going on. Don't rebound tenderness means I apply pressure to that McBurney's point, and when you press on it, the pain goes away, and then when I release it, the pain comes back. Okay, so that's called rebound tenderness, and that is an indicator of appendicitis. Like nothing else is causing that. Actions. If we are suspecting our patient has appendicitis, we're going to want to make them NPO because if they have to go to surgery, it's going to be quick, it's going to be emergent. So as soon as we can make them NPO, the better. We may want to be giving them fluids, comfort measures, obviously education related to OR. A lot of times these people like their head of bed elevated, that helps with the pain, so 30 to 45 degrees, and then almost kind of a fetal position is helpful just because it decreases the strain on the abdominal muscles. So like knees pulled up to the chest, maybe tilted to the side. We're going to talk about diet with them, and then if they go to surgery, advancing diet as tolerated, or if we're just kind of waiting for signs and symptoms to resolve, make them clear liquids or whatever till things get better. So teaching is going to be about ambulation after surgery, finishing antibiotics, all of that stuff, anything related to OR if they had to go. This is a safety alert, slide 26. If the patient is suspected of having appendicitis, the nurse should never apply heat because this increases blood flow and inflammation to the area and may cause the appendix to rupture. Excuse me, I ate a banana. I'm burping banana again, story of my life. Remember when we were talking about muscles, muscle pulls and stuff like that, we use heat because it opens up, it dilates, right? It vasodilates, it gets all that blood flowing, and that is good for muscles to start to feel better. But when we are talking about an organ that is inflamed, the last thing we want to do is bring more fluid to the table because our worry is that it can rupture. Okay. All right, moving on to colorectal cancer. So colorectal cancer involves cancer of the rectum and the large intestine. It is the third most common form of cancer and second leading cause of death in the US. Risk factors include a personal or family history, like a first-degree relative primarily. And then if you have any history of like polyps, inflammatory bowel disease, particularly UC for like 10 years or more. Let's see, obesity, high-fat diets, large amounts consumption of red meats, so greater than 7 servings a week. Also things like processed meats, cigarette use, alcohol, greater than 4 drinks per week. Not taking in enough fruits, veggies, I's and O's. Let's see, people with diabetes type 2 have a 38% increased risk. I mean, that's a pretty big risk, right? So one of the things that's interesting about colorectal cancer is they talk about these protective factors. And this is literally stuff that you can do just throughout your life that will protect you, that have been scientifically shown to protect you from developing colorectal cancer. So this is diets high in fruits and veggies, regular physical activity, regular use of aspirin or other NSAIDs actually, which is interesting. And then hormone replacement in postmenopausal women. So signs and symptoms of early stages colorectal cancer, they can just be kind of asymptomatic, right? Stuff that you can ignore. Also, your manifestations are going to differ very based on where the cancer is located. So stuff like unexplained weight loss and fatigue, like a lot of times that's going to be the first indicator. But there may be changes in like bowel regularity, appearance of stool, maybe blood in the stool, abdominal pain or distension, and then maybe a sensation of pressure, like they haven't pooped enough, basically. And then just kind of that not feeling well, like not really wanting to eat, nausea, vomiting, that sort of thing. So colonoscopy is the gold standard of diagnosis for colorectal cancer. Treatment, it's a cancer, so we may do chemo as an adjunct to improve survival rates. If the tumor cannot be completely removed, radiation can be used. And then, of course, surgical removal of the tumor based upon where it's located, how big it is, and its stage. So RN considerations, obviously vitals, electrolytes, fluids, CBC with diff, all of that. We want to make sure our person knows about the disease. And then if they are going for surgery, are they going to have drains afterwards? Like what's going to be their outcome? What does that look like? Actions, this person may need bowel prep. So bowel prep is something like polyethylene glycol solutions, like Go Lightly, where you drink it and you poop out everything you've eaten from every life you've ever had, right? And the importance of making sure that people do this is, especially if they're going to go in and use a scope, they won't be able to adequately use the scope if you have buildup in the bowel. So they will have to cancel the procedure, cancel the surgery, the whole thing. You'll have to go back, do Go Lightly again, you know. So it's really important that the patient understands the need to comply with all of that bowel prep. And it's not fun. You may as well not sugarcoat it, because it's not fun for people. So the better relationship we have with people, you know, the more likely they are to listen, take it seriously. Teaching, you know, there's going to be pre-op and post-op. And again, with this, we may end up talking to our patient about ostomy care, right? Depending if they have to remove a portion of the bowel, they may have a permanent or temporary ostomy. So that could be part of our teaching as well. This here is slide 29. There's actually a picture of an ostomy there, a really nice, healthy looking ostomy, if I do say so myself. Assessment, vitals, obviously. If they have gone in for surgery, we're going to be wanting to look for inflammatory infection things immediately. A mild elevation in temperature can actually be seen within the first 48 hours of a surgical intervention, and that's due to the inflammatory process, right? So, but we're going to want to be watching that. So after 48 hours, the patient should continue to be assessed for infection. This, of course, is like tachycardia, maybe a crazy temperature. Also, we're worried about fluid volume status. We're going to want to know what their H&H was. They just went for surgery. So did they lose a lot of blood? Did they not? You know, WBCs, nausea, vomiting. Our person may have an NG tube for stomach decompression. So of course we worry about our potassium. I's and O's, right? We worry about I's and O's. 30 mils per hour is pretty standard-ish, right? So we want to be watching that. And then if they have an ostomy, we want to make sure that the ostomy is draining appropriately, that it looks good, that we're not worried about it. Actions are going to be, you know, hanging the IV fluids, giving the meds, drain management if they end up with a drain, which is possible. Early ambulation. We want things to start moving. And then perianal care, if they don't have an ostomy, if they're still having bowel movements, those bowel movements may initially be loose. So we need to worry about that. And then we need to worry about the care around the ostomy, the skin around the ostomy, because the fecal matter can be acidic, right? So we want to make sure that that's being taken care of. This is box 58.4. This is very small. I'm not going to read it. There's a lot of information. But if you are not familiar with an ostomy, if you've not worked with an ostomy, you know, whatever, slide 30, box 58.4, this addresses ostomy care. Okay, so take a look at that. I think one of the cooler things about an ostomy is, depending upon where the ostomy is placed in the bowel, depends on what your stool looks like. So an ileostomy, which is honestly the one I am most familiar with, that stool is liquid to semi-liquid because it is at the very, very beginning of the bowel. So the fecal matter has not traveled through the bowel becoming fecal matter yet, right? So an ileostomy, it's going to be liquid to semi-liquid stool. It's not even really poop yet, okay? So then as we travel along the bowel, if you get into the transverse colon, so a transverse colostomy. Then we start to see semi-formed stool, but that descending colostomy, that's going to be semi-formed, okay, totally. Descending colostomy, semi-formed, and then a sigmoid, which is at the very, very end of the whole bowel, then you get totally formed stool because the fecal matter has actually traveled all through the bowel and become poop, okay? So if they have a sigmoid colostomy, those poops are going to be like normal poops. Now, the thing we have to consider, though, is we need those poops to be soft so that they can come out of the ostomy and not cause any problems, not cause any backup, all right? So ileostomy, liquid to semi-liquid. Sigmoid colostomy, totally formed, okay? And there's on slide 31, this is a picture. Slide 32. So this is just talking about abdominal trauma. So a lot of times this results from blunt trauma. So there can be a penetrating injury. It can be like stabbing, gunshot, motor vehicle. Motor vehicle is listed as the most common. You can have ped versus automobile, right? That's going to end up with abdominal trauma. Obviously, organs can be injured. Spleen and liver are most common. Hypovolemic shock can occur rapidly, okay? So anytime we have trauma to solid organs like the liver and or the spleen, you're going to have some hemorrhaging, right? So we worry about that. Our hollow organs, such as stomach, urinary bladder, intestines, we worry about like peritonitis because the contents of these hollow organs spills into the abdominal cavity where they shouldn't be. And think about the stomach with all that acid, the gastric acid and everything, right? And the intestines, you know, we're getting rid of toxins and waste materials and stuff like that. And all of that spills out into the abdominal cavity. So that's like perforation times 1,000. So we are really worried about sepsis at that point. So clinical manifestations gonna depend on the injury, right? It's gonna depend on the location, the extent, how many organs are involved. You know, is it open? Is it closed? What is going on? So you may see bruising, you know, all the things related to a trauma, right? Let's see. We will worry about bowel sounds because we're going to worry about what has happened to the bowels. Okay, that's going to be a priority. And then obviously for diagnostics, we're going to use CT, MRI, labs, you know, probably start with an x-ray to be honest, because we may have broken bones as well. So they'll start x-ray, CT, MRI. Treatment, totally dependent on what's going on with this person. One of the things with a trauma, so the book talks about starting a large bore IV. And this is just like trauma 101. And that's because we don't know what we're going to need to run. So you start with a nice fat IV and a nice fat vein that we're not going to worry about, so that if we have to run blood, open fluids, something like that, anything, we have the line to do it, okay? We may do an NG for gastric decompression. They may place a catheter because we're worried about hematuria. We also want to make sure that they are having adequate urine output. So, you know, and again, this is a trauma situation. So if you've been in the ED when they've rolled a trauma in or been out in the field, you know, or a medic somewhere, EMS or whatever, you know, this is what you're used to seeing, okay? Slide 33, safety alert, clinical manifestations of hypovolemic shock, restlessness, anxiety, cold, clammy skin, confusion, weakness, pale color, tachypnea, tachycardia, and hypotension. And again, remember, this is related to the fact that there has been a giant loss of fluid, okay? Or a fluid shift, right? It may not be open. It could just be an internal fluid shift somehow. If the patient experiences abdominal trauma and displays these clinical manifestations, the nurse should keep the patient calm and warm, elevate lower extremities unless contraindicated by other injuries, maintain a patent airway, and maintain IV access. Right, so we're just keeping this guy alive, right? We're keeping this guy alive until we can figure out what's going on with him. So RN considerations related to abdominal trauma, basically what we just talked about. It's going to be your advanced trauma life support protocols, you know, airway, breathing, circulation. We're going to worry about whether or not they can maintain their airway. We're going to worry about that hypovolemic shock. We're going to be monitoring vitals, doing all the things. This is going to be a team of people monitoring and working on this person all at the same time. I don't know if you guys have talked about the Glasgow Coma Scale before. So Glasgow Coma Scale, GCS, determines the patient's level of consciousness. And we are worried about that related to like head injuries and stuff. But the thing to know about the GCS is you can have a score of 3 and be dead, okay? That is factual information, okay? So GCS monitors level of consciousness, and you're obviously going to be using that with a trauma. They use that in the field as well, so that is information that will be conveyed to you when you take in a trauma. And what we're doing is hopefully that GCS improves versus decreasing, right? We never want to see a decrease in level of consciousness because that's not good. So we're going to be looking at a CBC, a urinalysis, electrolytes, you know, all the things, monitoring bowel sounds, worried about area of injury. We talked about putting in a large bore needle. If there's anything protruding from wounds, we do not remove things, okay? We let OR do that. We let a doctor decide if we can do that or not. We are going to follow whatever the doctor is telling us to do. Teaching, your teaching, if this is a trauma, your teaching may be to the family, right? So supporting the family, walking them through what's happening. You're going to have to get consent signed. You're going to have to find out about DNRs, all of that stuff. So there can be a lot. And then afterwards, it's going to be recovery for this person. And that is totally going to depend upon what sort of injuries they had. You may have wound care related to surgical, related to the trauma itself. Anytime the skin is open, we're worried about infection. So all of those things, it's just managing all of it. All right, chapter 59, hepatic disorders. All right, right upper quadrant. This is your liver, okay? Liver serves several functions. It stores blood, it filters blood, it produces bile, it does some synthesizing of clotting factors, right? Metabolizes carbs, fats, and proteins, detoxifies blood, storage areas for A, D, E, and K. Those are our fat-soluble vitamins, ADEC, A, D, E, and K, and then iron, right? So hepatic dysfunction occurs when the liver is no longer able to perform its usual functions. So risk for developing hepatitis generally associated with individual behaviors and exposures. Also, of course, there's hep A through E that can cause hepatitis, right? And those are transmitted by fecal to oral contamination or blood to body fluid, okay? So they're considered bloodborne pathogens, B and C, and we'll talk about those. So risk factors for hepatitis, chronic alcohol use, right? Probably the one we hear about the most. Prescription and over-the-counter meds, NSAIDs, right, can be really hard. Different toxins, and that is actually referred to as toxic hepatitis. So clinical manifestations, abdominal pain, irritability. You can get pruritus, so itching of the skin, related to the buildup of bile salts under the skin. Malaise, fever, nausea, vomiting, jaundice, right? Your eyeballs can get jaundice, your skin can get jaundice. We had this patient one time and she looked like a freaking highlighter. Like I have never seen somebody so yellow in my life. I honestly didn't even know that you could be that yellow. It was craziness. Um, Also, we're going to look at AST and ALT. Those are our liver enzymes. Okay, so they're going to indicate to us if our liver's doing okay. You may get clay-colored stools, and this is because of lack of bile in the stool. Basically flu-like symptoms. When we talk about the viral hepatitis, a lot of it presents as, especially initially, as flu-like symptoms. Okay, hepatitis can be acute or chronic. Acute hepatitis is less than 6 months, so chronic is longer than 6. And it can last a lifetime, right? The liver regenerates, but after a while, you just get so many complications. So meds could be oral antivirals. Also, the teaching with this is no alcohol. Okay. Hep C related cirrhosis is the most common reason for liver transplantation. And I thought this was interesting. I didn't know this, but liver transplantation occurs primarily from a cadaver donor, which I did not know, which is called an orthotopic liver transplant. So not that you have to memorize that, but it is a fun fact. Fulminant viral hepatitis is a severe, rapidly progressive, life-threatening form of active liver failure that includes neurological decline. So you're going to see this is going to be related to encephalopathy, insomnia, somnolence, impaired mentation. This is like crazy town dementia. This isn't like, oh, I think it's 1955. This is like, why is the purple cow on the ceiling yelling at me, right? Like, it's crazy town dementia. It's the same kind of level of confusion we see. This is built up ammonia. So it's the same type of dysfunction we see with buildup of CO2. It's a weirdo confusion. So with hepatic encephalopathy, there's going to be impaired mentation, that altered level of consciousness and confusion. It's characterized by numerous disturbances in the CNS, including motor function, changes in level of consciousness ranging from restlessness and confusion to seizure and coma. So it can go across the board. Your person can seem very anxious. Okay, it's gonna almost seem like the same anxiousness we see with people who are hypoxic and withdrawing off of something, where they just, it's just restlessness, and it can be combined with that confusion. So it's really interesting. Additional complications of liver failure include inability of the liver to produce clotting factors. So think about that. Think about the problem that is. So you can have coagulation disorders and thrombocytopenia. Okay, so the liver really does a lot for us related to blood. And so when we have liver dysfunction, we have to start looking at, like, am I worried? Transfusions, am I worried about this person bleeding? Am I worried about all that bruising? What's going on with this person? All right. Slide 38, table 59.1, talks about the different types of hepatitis. This first one here is A, B, and C. To be honest, nobody really cares about D, E, or G. I even forgot about G. D can only co-infect people who already have hepatitis B. E, I don't even remember anything interesting about, and who even knows with G. Um, so A, B, and C is what we care about. This talks about vaccines. There are vaccines available for Hep A and Hep B. So this is slide 39, table 59.4. RN considerations related to hepatitis. Oh, there's a picture of some jaundiced eyeballs for you. So activity intolerance, pain, right? Altered nutrition, altered thought process related to that encephalopathy, and then knowledge deficit related to why they're in this position in the first place, especially if this is related to ETOH, right? Our assessments, obviously vitals, liver enzymes, serum bilirubin. We're going to be monitoring for jaundice, right? Nutritional intake, daily weight. We're going to want to talk to them about intake of fatty foods and alcohol. If they have a transplant, that's a whole other thing, because then we get into signs and symptoms of rejection of an organ. So that is a special area that you would be specially trained for if you were in that position. Actions, meds as ordered, small frequent meals, antiemetics as needed, right? They may feel nauseous. We want physical activity, but also we do want them to rest. And then we want to have them do strength and conditioning. So teaching is going to be related to nutrition, diet, good hand hygiene, because with the viral hepatitis A, we associate that with fast food workers, right? Fast food workers who use the restroom and then pack up your Happy Meals. Yeah, don't wash their hands in between. So you're going to want to talk about good hand hygiene, because with the virals, it really does matter. Also, if we're talking B or C especially, needle sharing, right? Unprotected sex, that sort of thing. Avoid behaviors that can increase risk of transmission. Also, there's vaccinations available for Hep A and Hep B. So for Hep B, they do recommend that for healthcare workers. You know, it's a 3 vaccine series that you can get, and it's pretty good. It's like over 90% effective. So in the grand scheme of vaccines, that's pretty good. Also, if we are talking about Hep A, we're going to want to find out about water sources if we have not identified it related to, you know, literally the person pooping and transferring the Hep A. So Hep A is also the one that like ends up affecting, they've had it in like swimming pools and like community swimming pools and stuff like that, because a little baby or somebody poops in the water and then all of it gets infected. It's lovely. This talks about cirrhosis, okay? So cirrhosis is the end result of most chronic liver disease. So it's generally irreversible once it starts to develop, and treatment is focused on preventing progression and complications. At the end stages of cirrhosis, liver transplant's your only option. So risk factor includes chronic infection with A, B, or C, or chronic alcohol use, biliary disease, some autoimmune diseases, believe it or not. Improving health habits and refraining from risky behaviors such as needle sharing and unprotected sex, refraining from consumption of alcohol, and receiving vaccinations for hepatitis are steps that can be taken to help prevent cirrhosis. Cirrhosis of the liver is caused by several different factors, including, you know, the viruses, alcohol, biliary disease, fat in the liver cells, and then genetic and autoimmune. Most common cause of chronic infections is Hep B and C, and then ETOH, okay? There's also this thing called non-alcoholic steatohepatitis, so NASH, and that is commonly found in obese patients. And it is caused by the accumulation of fat in the liver cells. And so this leads to inflammation, and then the inflammation ends up in cirrhosis. So this is going to be treated by liver biopsy. And there's really no coming back from this. Like once that process has begun, the best thing we can do is to keep it from getting worse. So our diagnosis is CT, EGD, ERCP. ERCP is endoscopic retrograde cholangiopancreatography, right? So it's an endoscope with a fluoroscopy to visualize the biliary system, to diagnose and treat causes of obstruction in the biliary trees. They'll also do a biopsy. So treatment, you get ascites. You'll see ascites a lot, right? That's going to require restriction of sodium intake to less than 2 grams per day. Less than 2 grams per day, right? That's a big restriction. Probably going to be using diuretics on this person to help get rid of that salt and water. Hepatic encephalopathy, you want to avoid protein overload. This helps decrease bacterial production of ammonia, because it's that ammonia that causes that crazy confusion. You can give people lactulose to help get rid of ammonia. It binds to the ammonia and people poop it out. That is a nasty poop. Patients should also eat small frequent meals to prevent protein loading. They may use neomycin and lactulose related to the bacterial ammonia buildup. Neomycin is a broad spectrum antibiotic that destroys bacteria normally present in the GI tract. So decreasing protein breakdown and production of ammonia. So this bacteria is literally like fermenting the ammonia, right? That's how you end up with that buildup. And then lactulose, like I just talked about, excretion of ammonia in the stool, okay? And again, that is a yucky poop, so watch out. Our assessments related to cirrhosis, our RN considerations, we're going to worry about respiratory, what's going on. We're going to worry about ascites. We're going to have fluid buildup. So, are they breathing okay? Do I have a lot of fluid in the lungs? Do they have shortness of breath? Vitals, the usual. Blood pressure, all of that. I am going to worry about peripheral edema because of fluid retention. And then I'm going to be monitoring the abdominal girth because of ascites, right? You can have fluid shifts within the peritoneal cavity, and we just want to keep monitoring that. We're going to look for signs and symptoms of bleeding. Think about nosebleeds. Right? What about bleeding of the gums? Petechiae. Petechiae are these small round spots on the skin, and they are usually a result of bleeding. They look like if somebody stuck you with just like a safety pin, right? And left a little red spot on your skin. That's kind of what petechiae looks like. Let's see. So there's going to be, don't forget that if something's wrong with the liver, we're going to have a decrease of clotting factors. So that can be bad. We're going to be monitoring the skin, the sclera, the urine, the stool. Skin and sclera, we're looking for signs and symptoms of jaundice. The stools, we're looking to see if they are clay colored related to lack of bowel. Mental status, we talked about that. Eyes and nose. Daily weights, fluid retention is a big thing related to this. So daily weights for sure. And then, of course, our acid-base disorders. If our person has had a liver transplant, we're going to worry about organ rejection. We're going to give all our meds as ordered, including any electrolyte replacements. Teaching, if this was alcohol-based, we're going to teach about stopping the alcohol, not just cutting back, but stopping, right? If this is related to needle sticks, sharing needles, unprotected sex, with C, B, lifestyle changes. If this was exposure or bad habits like not washing your hands, we're going to teach about that, okay? Liver cancer. So liver cancer often asymptomatic until the liver becomes enlarged or the patient demonstrates clinical manifestations of liver dysfunction. The tumor typically impairs normal functions of the liver, so patients are going to exhibit abdominal pain, weight loss, anorexia, weakness, fatigue, jaundice, and ascites. Prognosis for patients with primary liver cancer is poor because patients are usually asymptomatic and are not diagnosed until late in the disease process. If diagnosed early, they can do surgery to remove that tumor. And especially if the liver is otherwise healthy, it's a pretty good outcome with this. However, because in a lot of patients, the liver tumor goes undetected until like it's metastasized or gone to the lymph nodes or whatever, you know, it can be problematic. So the person may have a right upper quadrant pain with extension to the back or shoulder. We're going to see that fluid accumulation, jaundice, all of that. Your liver enzymes, AST, ALT, will be elevated. Bilirubin will be elevated. Priority problems, pain, activity intolerance, ascites, and risk for ineffective coping, right? Assessments, same as we talked about before, shortness of breath and breathing because of fluid accumulation, vitals. We're worried about abdominal swelling and bloating, weakness, weight loss, nausea, vomiting with electrolyte imbalances, jaundice, urine color, abdominal girth. We're going to administer meds as ordered, of course. And teaching is going to be based on what the outcome looks like, right? You know, if it's early and they get everything out and the patient's going to be fine, then we talk lifestyle changes, perhaps. If it's more palliative, then we talk more palliative, right? All right, moving on to chapter 60, biliary and pancreatic disorders. All right. So cholecystitis, this is your gallbladder, okay? Inflammation of the gallbladder caused by an obstruction of bile flow and is classified as either calculous cholecystitis, which means you have gallstones, or acalculous, which just means you don't have gallstones, okay? So gallstones are hard deposits formed from bile contents that often cause obstruction of ducts in and around the gallbladder. Risks for gallstones, so the 5 F's, ready? Fair, fat, female, fertile, and over 40 years of age. So risk factors for gallstones include obesity or rapid weight loss surgery, eating large amounts of foods with saturated fats, pregnancy due to elevated progesterone levels, genetics. This is interesting. Members of the Pima and Chippewa tribes may have increased risk, and some meds. So estrogen, octreotide, and cholesterol lowering medications. Octreotide is a med they use with like severe GI stuff. And I cannot remember if it's to slow down motility. I think it's to slow down motility, but I'd have to look it up. I just know octreotide is used with GI things. Clinical presentation of acute cholecystitis ranges from no physical findings to pain and tenderness in the right upper quadrant. There can be rebound tenderness. Remember that rebound is where like I push in and the pain goes away and then I release and it comes back out. And we see that with appendicitis at McBurney's point, okay? Pain associated with cholecystitis is due to the release of cholecystokinin, which causes the gallbladder to contract. Okay, so it's spasming on you, so that's causing your pain. Pain can be described as colicky, which is intermittent and radiating. It can radiate to the back. So you can also have pain related to the movement of gallstones through the bile ducts. As the bile flows, the stones may flow with it. Some patients exhibit a positive Murphy's sign, which is pain on palpation of the right upper quadrant, okay? Murphy's sign, right upper quadrant. Risk factors for acalculous cholecystitis, so no gallstones. So abdominal surgery, trauma, long-term IV nutrition, so being on like TPN for greater than a month, prolonged fasting, sickle cell, diabetes, endotoxins, AIDS, salmonella, CMV. So diagnosis, we're going to use X-ray, ultrasound, HIDA-scan. HIDA-scan is hepatobiliary immunodiacetic acid scan. Okay, I'm probably saying it wrong, but it's a HIDA scan. That is what you'll hear, HIDA scan. It's a nuke med scan. So what they do, it's really cool actually. They use a radioactive tracer to study the production and flow of the bile. So what they do is they put this you swallow the radioactive tracer, and then they go in and they see how this radioactive tracer is flowing through the ducts. Like, is it getting stuck somewhere? Is it flowing at the rate that we would expect? Is it getting caught up? You know, whatever. So nuke med studies are pretty cool. They can also do an ERCP, which is that endoscopic retrograde cholangiopancreatography. We talked about that earlier. All sorts of stuff. So treatment, laparoscopic cholecystectomy, right? Lap chole. The biggest thing is your patient's going to be nothing by mouth. They're going to need IV hydration, maybe electrolytes, and then IV antibiotics as indicated. So food considerations. Several foods contribute to the formation of gallstones and should be avoided. Fatty foods such as fried foods, ice cream, dairy, red meats, and heavy alcohol consumption should be restricted because they promote gallstone formation. Patients are advised to choose foods low in saturated fats, including rice, potatoes, pasta, yogurt, fruits, lean meat, and whole grains. So shocker, once again, if you eat a better diet, you will have better health outcomes. Slide 46 is a safety alert. Because patients may develop SIRS after ERCP, it is important that the nurse monitor the patient for tachycardia, hypotension, change in body temp, increased respiratory rate, and an abnormal WBC count after the procedure. And SIRS is systemic inflammatory response syndrome. RN considerations related to cholecystitis, so pain, obviously, fluid volume deficit, nutrition. We're going to want to talk to them about discharge needs, jaundice. You know, if we're worried about their diet, you're going to have to do teaching about diet. Assessments, obviously, vitals. We are worried about development of SIRS, so we would be looking for tachycardia, increased respiratory rate, hypotension, and then changes in body temperature. All right, we're always worried about electrolytes. Our person may have nausea and vomiting, so we're worried about electrolytes. WBCs, our liver enzymes, bilirubin, signs and symptoms of dehydration. We're going to want to know what's up with the bowels. What are the sounds? And then, of course, there's the Murphy sign. Okay. What is the stool looking like? You can have steatorrhea with gallbladder problems. We're going to do daily weights. We're going to keep our person NPO until we feel that that gallbladder is not as inflamed, or, you know, or the doctor tells us, right? We're going to administer meds as ordered, probably an NG tube for low wall suction to help decompress the stomach. Post-op teaching, you know, really the foods, right? With post-op teaching, it is the foods. And then looking for overall disease improvement or worsening. So like if your eyeballs are yellow again, if you have signs of fever and chills, dark urine, light colored stools, right? All of that stuff. Acute pancreatitis. So this disease is characterized by inflammation of the pancreas and classified as acute or chronic. In acute pancreatitis, patients usually present with life-threatening conditions that require hospitalization, frequently in the ICU. Acute pancreatitis is an inflammation of the pancreas that can be mild to severe and affect people of all ages. Patients with a mild case of pancreatitis have no end organ dysfunction and have low mortality rates. Mild pancreatitis is self-limiting, and 85% of patients fully recover. Patients with severe acute pancreatitis may develop SIRS and end organ dysfunction. Severe acute pancreatitis has a mortality rate of 15 to 30%. That's pretty high, right? Most prevalent causes of acute pancreatitis are gallstones and alcohol. So our signs and symptoms: sudden onset of epigastric pain. It's going to be felt in the upper left quadrant to mid-abdomen, and it can radiate to the back or the shoulders. This pain is usually characterized as being like a deep pain and sharp. It's going to become more intense within minutes of eating food that is high in fat content, okay? Your body's like, no. The pain can be constant and severe and last for several days. Some patients can even have severe pain when lying flat or bending forward, and it can be associated with nausea, vomiting, not wanting to eat. They're going to have abdominal fullness, bloating. Hiccups are kind of a weirdo thing that you'll see. But there can be indigestion problems. You may have a fever related to the inflammation, tachycardia, and hypotension. Diagnosis, physical exam, right? We're going to look for that tenderness, guarding, rebound tenderness, lab, CT, MRI. Treatment, person's going to be NPO. Believe it or not, if you were to continue eating, the pancreas releases the enzymes that are responsible for autodigestion, and the autodigestion enzymes will eat the pancreas, right? So you want to make your person NPO. Typically, patients should not receive any oral fluids or food until abdominal pain and tenderness have subsided and bowel sounds are heard. We're going to use IV hydration. Let's see, complications. Necrotizing pancreatitis occurs in approximately 20% of all patients with acute pancreatitis and is associated with a high rate of complications and high mortality rate, up to 50%. Necrotic pancreatitis may present one or more weeks after the initial onset of acute pancreatitis. It can be diagnosed by CT. It's going to show the presence of air and gas surrounding the pancreas. And it's caused by activation of pancreatic enzymes that basically eat through the tissue of the pancreas, like acid disintegrates nylon, and enters the peritoneal cavity and surrounding tissue, causing extensive peripancreatic tissue breakdown, inflammation, and hemorrhage from the rupture of surrounding blood vessels. Patients with necrotizing pancreatitis can develop sepsis, shock, and multiple organ dysfunction. How is that for you? Here is a safety alert, slide 49. Monitor closely for complications of hypocalcemia in patients with acute pancreatitis, including Chvostek's, Trousseau's, tetany, and laryngospasm. The low calcium levels are caused by the chelation of calcium salts by increased fatty acids. All right, so our priority problems, definitely pain. And then ineffective breathing related to pain, right? Nutrition, fluid volume deficit, all of that. We're going to be looking for fever, okay? We're going to be looking for signs of dehydration related to fluid shifts, O2 status, pain location, intensity, and duration, abdominal assessment. Our pancreatic enzymes are lipase and amylase. All right, so elevated lipase and amylase are due to the inflammation of the pancreas. So serum lipase levels are a useful diagnostic biomarker in pancreatitis because levels can remain elevated for up to 2 weeks. Elevated amylase levels that are 3 times normal are indicative of acute pancreatitis. These levels are elevated within 12 hours of the onset of inflammation, and elevation can last approximately 4 days. Okay, so amylase and lipase, all right? Also serum glucose. Glucose elevations due to the digestion of the pancreas, which leads to decreased production and availability of insulin. So blood sugar may be up. Also, we're going to worry about calcium, okay? So the signs of hypocalcemia. Stool color, you can get these clay-colored stools because of obstruction of bile flow, and steatorrhea, which is the greasy, poopy stuff. So we're going to worry about nutrition, daily weights. We're going to keep our guy on NPO status, all right? Probably an NG tube to low wall suction, administer meds as ordered. Teaching appropriate diet, right? All day long, appropriate diet. Small frequent meals, no alcohol, no smoking. And then we want them to know the signs and symptoms of the disease process so that they can report to the physician if anything seems to be getting worse. All right, chronic pancreatitis. So this is persistent inflammation that causes scarring and damage to the pancreas and surrounding tissue. Inflammation of the pancreas that occurs when digestive enzymes auto-digest the pancreas and surrounding tissues for a prolonged period of time. Because of inflammation and scarring, the pancreas is unable to make the digestive enzymes necessary for the digestion of proteins and fats or the hormones necessary to regulate glucose. So insulin and glucagon, right? Fibrosis of the pancreas secondary to the chronic inflammation is associated with chronic pancreatitis and further contributes to the loss of normal pancreatic function. Most common cause of chronic pancreatitis is excessive prolonged alcohol consumption. Chronic alcohol use, hereditary disorders, cystic fibrosis, which we talked about, stuff like hyperlipidemia, hypercalcemia, and some autoimmune disorders can also cause chronic pancreatitis. Our signs and symptoms are going to be upper abdominal pain, which can spread to the back. Pain is often constant, and it's kind of like a recurring epigastric and lower upper quadrant pain. The pain's going to be exacerbated by alcohol and overeating. Let's see. You can have nausea, vomiting, weight loss, diarrhea, steatorrhea, we talked about that, pale or clay-colored stools. Diagnosis, CT, ultrasound, ERCP. Treatment, pain management, right? Fluid replacement, electrolytes, nutrition, insulin therapy because the glucose levels are going to be elevated. We also can replace pancreatic enzymes, okay? So that's going to help with malnutrition and malabsorption. Let's see. They may do surgical resections on the pancreas. They are very high risk. Like, I know one person who's had a pancreatic resection and he's fine. I know multiple patients who it did not go so fine. So that is very high risk for people. Our priority problems, pain for sure, and hopelessness, especially if we're dealing with something chronic and progressive, right? Assessments, vitals, serum blood glucose levels, amylase and lipase levels, bilirubin, weight, jaundice, what the stools look like, actions. We're going to administer meds, you know, as ordered, provide rest in a calm environment. We're going to collaborate with a dietitian to come up with a meal plan that is acceptable for our person, right? Teaching is avoiding alcohol, taking your pancreatic enzymes as prescribed. You do not chew the pancreatic enzymes. Limit fat in the diet. Avoid irritating foods. If there's an alcohol problem, finding support like AA or some other group to help deal with that. So pancreatic cancer, third most common cause of cancer-related deaths in the U.S. Really no reliable screening is the problem. So clinical manifestations pretty vague until you get pain, jaundice, that sort of thing, and then you go to the doctor and they start rooting around and identifying things. So the pain can be dull pain in the epigastric area and back. Eating and activity may increase the pain. Lying flat can increase the pain. Exact cause of pancreatic cancer not known, but high association between smoking. Smokers are twice as likely as non-smokers to develop pancreatic cancer. Obesity, diets high in fat, consumption of meat, fried foods, refined sugars, nitrates. And then occupational exposure to gasoline derivatives and benzidine. Okay, so one of the things is that these things are modifiable risk factors, right? So, people have to consider making some choices. Let's see, diagnosis, ultrasound, CT, MRI, ERCP, the huge. Treatment, current evidence for the use of adjuvant therapy recommends chemo and radiation. It's obviously going to depend on the stage, size of tumor, all of that. Surgical resection. With a surgical resection, it's potentially curable, okay? However, not a lot of people fall into this category. If the cancer is spread to the lymph nodes or there's metastasis to the liver, then there's really nothing they can do. Okay, it's bad. There's a Whipple procedure if the cancer is in the head of the pancreas. If you don't know what the pancreas looks like, it kind of looks like a semicolon, kinda, right? Or a comma. I guess it looks like a comma, not a semicolon. So that also has a period. Pancreas does not have a period. So it looks like a comma. So the head of the pancreas is the tiny part. So here's a picture for you. This is a safety alert related to the Whipple. So after a Whipple procedure or pancreatic duodenectomy, NG tubes are maintained post-op to decompress the stomach, prevent bloating, and remove gastric acid secretions to minimize pressure on the surgical site. These NG tubes are placed intraoperatively and are not to be manipulated in any way. A do not manipulate NG tube sign is placed on the wall above the patient's head. These nasogastric tubes are not to be repositioned, irrigated, or checked for placement because these actions can cause a breakdown of the anastomotic site. If a patient removes the NG, it is not to be replaced by the nursing staff. A member of the surgical team is to be notified. So this has NCLEX written all over it, okay? Because this is, as a nurse, having to know that A, your person had a Whipple, and B, that NG was surgically placed, and we cannot just replace it. Okay, and we are used to replacing NGs all day long, right? So, and let's say your person had a Whipple, and chronic pancreatitis. Could they have been an alcoholic? Could they be going through withdrawals? Potentially, right? Potentially. So, if they have cancer and this has become a chronic problem, that's your person that's going to be a little loopy after surgery, and pull those for you. Anyway, definitely pay attention to that slide 54. I would put that in your brain where you can retrieve it. RN considerations related to pancreatic cancer, pain, nutrition, anxiety, jaundice, pruritus. Remember, they get that pruritus related to buildup of the bile salts underneath the skin. Vitals, I's and O's, the glucose, the weight, muscle mass, cachexia, people who have pancreatic cancer and end up with like Whipple procedures and whatnot, remember that your pancreatic enzymes are really a huge part of breaking down foods so that we can absorb the nutrients appropriately. So a lot of these people are super skinny. They look malnourished, right? And that's what that cachexia is. It's not just weight loss, it's muscle loss. And it's muscle loss that you're not gonna get back. So these people just look malnourished, okay? So you're gonna see that. Let's see, we're gonna worry about abdomen and bowel sounds, all of that. Let's see. Don't forget about never manipulating the nasogastric tube after a pancreatic procedure. We're going to be monitoring for fluids, teaching, obviously cigarettes and alcohol need to stop, med regimens, okay, diet, nutrition, pancreatic enzymes, all of that stuff. Also, this may be a palliative care situation. So coping skills, palliative care, support groups, that sort of thing. And that's going to be patient and family, right? Because it's usually not just the patient going through this alone. So that concludes GI. Holy cow. Thank you guys.